It's really great to be here, and this is post-lunch, so it's a good topic while your stomachs are full. And this is what I also say, plan your meals or think about it when you're not super hungry. If you're going to make choices for food, make them when you're full and plan the next meal. If you're very hungry, you're going to make choices that aren't great for you because you'll pick the fastest food that you can get. So these are my disclosures. And then, what food or supplements can I take? The most commonly asked question by patients, the least likely to be answered question by oncologists. And so I think that there is a real unmet need here for dietary research to be able to help patients better. And so this is just an example of a patient of mine with myeloma. And you can see that, managing myeloma in itself, we've talked about how complicated it is. But if they have so many other medical problems, doesn't that really compound the complications in terms of how we can manage their disease? And because of these comorbidities, this patient was not a candidate for stem cell transplant, CAR T cells, clinical trials. So that, of course, affected their survival. So while we talk about, what's the best therapy, we also want to talk about how do we ensure that we are able to even get these therapies. And what I've highlighted in green are things that I think could have been avoided or prevented with lifestyle changes over their lifetime, or even, thinking about them later. So through the HealthTree Foundation, as you heard about, the research aspect of it, we were fortunate to be able to survey over 421 patients with plasma cell disorders. And we asked them questions like, since your diagnosis, have you had questions around diet? Has your oncologist addressed it? And you can see the majority had questions, majority felt their oncologist didn't address it. And the majority said that if their oncologist would address it, they would at least attempt to listen to it and follow it. So patients do want to make changes. And what's most interesting in green is that patients actually showed, I thought that patients would say we don't make any, patients don't make any changes once they're diagnosed. But we asked patients before your diagnosis and after your diagnosis, how many times a week did you eat certain food groups? And we saw that there was a really significant increase in the healthy food groups that patients were eating after their diagnosis. So patients are making changes whether, we tell them or not. The American Institute of Cancer Research has these very nice guidelines on cancer prevention and also information of specific foods to eat and avoid for cancer. I encourage you to go to this website if you have specific questions. If you click on each of the food group, foods that you see here, they have very detailed information and data on it in terms of evidence. And what you can see out of these guidelines, 6 out of the 10 that you see on the right are actually related to diet and nutrition. So the majority are something that could be thought about in terms of nutrition. Healthy lifestyle, and we talk about genetics, and I think genetics is very important to, as we've talked about risk stratification. But what about lifestyle in the situation when you have bad genes or good genes? Can it make a difference? And we can't do much about the genes that we have in the myeloma, but if we do something about the lifestyle, will it make a difference? And I think that this study, even though it's colorectal cancer, I want to show it because I think it's very interesting. What you can see here on the, here you see at the bottom, they talk about healthy, intermediate, and unhealthy. So they've calculated a lifestyle score and divided patients into a healthy lifestyle, intermediate lifestyle, and unhealthy lifestyle. And then they've also taken these same patients and classified them into a low, intermediate, or high risk in terms of genetic risk. And then they looked at, the interaction between that. So where you see the high genetic risk, you also see the black bar is the unhealthy lifestyle compared to the white bar, which is the healthy lifestyle. And what you can see is, let me see if this pointer works. Okay, great. So what you can see is that if you have bad genes but a healthy lifestyle, it's almost similar to the intermediate risk here. And so there is something where lifestyle can modify risk terms of genetic risk. And this is colorectal cancer, so I understand this is not myeloma, but this is just something to think about in terms of, until we have data in myeloma. What about dietary patterns and cancer? So there have been a lot of large population studies. So these are like epidemiologic studies looking at large populations and saying who gets less cancer. Now this is just dietary patterns, right? So they have to think about like how to classify people. And in each of the studies, they've used different things. So in this French study, they calculated a dietary score on how much plant foods they eat. In this one, they divided patients into vegans, vegetarians, non-vegetarians. I think in this one, they did vegans, vegetarians, seafood eaters, and meat eaters. And then they looked at over time, they followed these patients for decades and said who gets more cancer, and what's the risk of it. So all three studies are showing very similar things, that there's about a 15 to 20% reduction in cancer risk with more plant-forward diets than if somebody's eating less plant-based foods. What we also know in myeloma is that there's this nurses health professional study, and the nurses health professional study again categorized diet into the alternative healthy, like these different pre-diagnosis dietary patterns, and then saw that if you had one of these in green, which are healthier dietary patterns, and the common theme in them is that they all have like plant-forward patterns, they have 15 to 24% lower myeloma deaths, and the Western diet had 15 to 24% higher risk of myeloma-related deaths. There's the same EPIC Oxford study from the UK that I talked about. You can see that the vegans and vegetarians had 77% less likelihood of developing myeloma than meat eaters, but I understand this is a small study. There were only 65 myeloma cases because myeloma is rare. But we want to change that, and so we are studying some of this in other populations. This is the first time I'm showing this data, but what you can see here is that we looked at MGUS risk. So there is very little data around does diet affect risk of MGUS. There's only one other paper before this, and in this paper what we're looking at is 373 individuals with MGUS. We matched controls, so people who don't have MGUS, and looked at dietary patterns. And what you see is, and we match them based on age, BMI, sex, race. And what you can see is that this is an odds ratio. So anything more than 1 means increased risk. Anything less than 1 means a reduced risk. And so foods that were associated with a reduced risk are whole grains, fruits, vegetables, cruciferous tomatoes. And what was increased risk was sugar-sweetened drinks or beverages, colas, and all of that. So it's again pointing towards the same thing that, the cancer prevention guidelines that I showed you from AICR talks about avoid sugary drinks and eat more plant-forward foods. We also looked at pre-diagnosed dietary patterns and myeloma risks. So I showed you the data from the nurses health study, which had 423 myeloma patients. And now I'm showing you data from 1366 myeloma patients. So we believe that this is the largest study to date. And we are again going to be presenting this at ASCO. So this is very early data that I'm showing you. But what you can see is, again, that we calculated these different dietary scores. So, the food frequency questionnaire that we're doing the survey through HealthTree Foundation, when patients fill that survey out, you can calculate a dietary score with that information. So we calculated these different dietary scores for the surveys that patients had filled out in this study. And then we looked at different quartiles, meaning that the higher quartile means they have a healthier diet, and the lower quartile means less healthy. And you can see that the only one that we see some significance with is the healthy plant-based diet index, meaning that those who ate more plant-based foods seem to have a lower risk of developing myeloma. Now I wanted to just switch to a few specific foods that, sometimes the controversies come up with. So one is whole grains. So people assume that whole grains are carbs, and so because carbs are sugar and sugar is bad, that we should not be eating any carbs. But remember that refined carbs and complex carbs are very different things. And yes, while I do say you should be avoiding refined carbs as much as possible, like sugary drinks we talked about, whole grains are actually very healthful. Oats, brown rice, quinoa, buckwheat, barley, all of those things are things you want to incorporate in your diet and not avoid, because they come with many things other than just fiber, and I'll talk about that. So this is again a study with overall cancer risk, and you can see that eating 3 servings a day was associated with less decrease in total cancer mortality in both these large studies. A lot of the data is from colorectal cancer. So the recommended daily intake is 3 servings of whole grains a day, which is about 90 grams. And what you can see here is that whole grains are not just fiber or not just sugar. They have a lot of other things, which is why they probably are having these effects. Another thing I wanted to talk about was red and processed meat. And we don't have data much for myeloma. There's maybe one small study with that. But the reason I'm bringing it up is because this was a paper published in 2015. The IARC, this International Agency for Research on Cancer, what they do is they take certain, like, you were asking about the environmental factors or what could cause cancer. They actually work on finding all the evidence and determining whether a certain chemical is a carcinogen or a food group is a carcinogen or not. And they look at all the evidence available. So they've looked at over 800 epidemiologic studies. I grant these are population studies. But what they see is that there is data for colorectal and other types of cancer and pancreatic, prostate cancer, stomach cancer with red and processed meat. And so with this information and this paper, processed meat is actually considered a group 1 carcinogen, means it's definitely carcinogenic for colorectal cancer. Red meat is considered a group 2A carcinogen, meaning it's probably carcinogenic for colorectal and these other cancers. But this one has the most data for colorectal. So avoiding processed meats as much as possible and red meat, I think, is always healthy. And these are some of the mechanisms they talk about and are in other papers as well, where there are different mechanisms through which this may be happening. And I really like this paper, which is not in, again, myeloma, but it's, again, looking at colorectal cancer. But what they did is they did whole exome sequencing from 900. So they looked at the genes in 900 colorectal cancer cases, and they've looked at this alkylating mutational signature that they found. And then they said, look at high intake of certain meats and low intake. So in each group, fish, chicken, and red meat, they've, what you see in gray is the high intake, and then this is the low intake. And what you can see is for these numbers in red means it's significantly different. And you can see that red meat, processed or unprocessed, and overall was associated with more of this alkylating signature than if there was low intake. So people who had high intake of this red and processed meat had more of this alkylating signature in their tumors. And then they went on to say that they characterize this alkylating signature into, do you have a lot of the alkylating signature, which is quartile 4, or a little bit of it, which is quartile 1. And they showed that those who had the highest alkylating signature had the lowest survival, showing that, how there's a mechanism here that they're able to show of how diet may be affecting the mutation, so the alkylating signature, and then survival too for colorectal cancer. I think this study shows mechanism, which is nice, but we don't have something like that for myeloma. Next, I wanted to talk about the gut microbiome, and we are more microbiome than human cells. We are more microbiome genes than human genes, and that's just something to keep in mind when you're, thinking about yourself. Is like you want to also feed the microbiome and think about looking after it. And some things you can do to look after the microbiome is fiber, getting enough fiber in your diet. And the microbiome affects the immune system, inflammation, and a lot of different factors around it. So you can see that the microbiome is not just what the bacteria in your stool, but they play a very significant role in disease and health overall. So, what are the factors that affect the immune system? So when we think about the microbiome, could be one of them, but what about other factors? So we do know that, there are non-modifiable factors, things we can't do anything about. But there are also modifiable factors, that some things that are in our control that we can do something about. And we decided to focus on the ones that we can do something about and understand, if we do change these things, does it really affect cancer? And so these are just a few other studies in healthy individuals that I wanted to show you because I think they're very interesting. These were African Americans and rural Africans who were asked to participate, only 20 patients in each study. They were, for 2 weeks, they were asked to switch diets. So the African Americans ate the rural African high fiber diet, and the rural Africans ate the African American Western diet. And then what you see is that they showed a these were healthy patients. They did colonoscopies before and after the intervention, and they took biopsies. what you can see here is the tissue biopsies and staining. They see a decrease in the proliferative index of these cells. So, tumors that are more proliferative or less proliferative, these are normal healthy cells, but they already in 2 weeks are seeing changes in proliferation of the cells, changes in immune function of these cells, as well as changes in the microbiome with healthier butyrate producers increasing in the African Americans after changing their diet. And so that's one concept about it can change pretty quickly. Even 2 weeks can be enough to have dietary changes. Another thing is the concept of diversity of your gut microbiome. So we talk about okay, yes, we want healthy bacteria in the microbiome, but we also want a healthy diversity of the bacteria. And the reason is I don't have time to go into those papers, but there are a lot of studies showing that if you have a more diverse microbiome, you're more likely to have longer survival post-transplant and things like that. Now, we don't have studies looking at can we alter the microbiome or change it, but we do know in healthy individuals, and this study was with over 10,000 individuals, that if you are eating more diversity of plant foods, so more than 30 plant foods per week, you have more diversity of the gut microbiome, reduced antibiotic resistance genes compared to if you eat less than 10 plants per week. And when we talk about per week, we're not talking about eating spinach 10 times in the week, but we're talking about eating spinach, broccoli, beans, herbs, different things. So, eating a variety of 30 different types of foods per week, because I think each food is feeding different bacteria and the different, helping them stay alive in the microbiome. Another thing that affects the immune system is looking at dietary patterns, and you can see that high fiber diets are associated with increase in the immune function, microbiome function like short chain fatty acids, but also maybe personalized changes in inflammation. And then eating fermented foods was associated with this diversity that we talked about. So the variety of foods, the fermented foods, and reduction in inflammation as well. So the next part I wanted to talk about is how do we think about this when we study cancer? So I've talked a lot about population studies, association studies, and that's really what the kind of evidence we have in nutrition at this time. But, in the prevention setting, can we use diet to prevent further, a second cancer, maybe relapse or other medical problems? And the American Institute of Cancer Research actually just does say that if people followed a healthy lifestyle, about a third of cancers could be prevented in the world. So, it's a big number that we could impact. And so the other thing is looking at with treatment. So if we have a healthy lifestyle, can we tolerate treatment better? Could we have a synergy with treatment? And then the same thing is in the survivorship space. Can we have longer time in remission if we're doing, having a healthier lifestyle? And so with that, we wanted to study this, and we did this pilot study called the Nutrivention Trial. We do know that patients who have MGUS or smoldering myeloma who have an elevated BMI are actually twice as likely to progress to myeloma than if they have a normal BMI. So can we tilt the scale for this by, maybe helping patients change their lifestyle, eating a healthier dietary pattern, maybe reducing weight if they have an elevated BMI, and see what the effects are on this? And so what we did is this Nutrivention pilot study that opened in 2022, finished enrollment last year, and now will finish the study this year. And you can see that we enroll patients with MGUS and smoldering myeloma with a BMI over 25. So these are pre-cancerous states or before myeloma has developed. And we actually ship them lunch and dinner for 3 months, and we give them meals for 3 months, and then we gave them nutrition coaching for 6 months, and then we followed them for a year on the study. We also collected blood, stool, and other things, and you can see here that we enrolled a nice population of minority patients. We had a nice variety. We also had MGUS, smoldering, and different BMIs, and a third of the patients were also diabetic or pre-diabetic. What you can see is that 3 patients dropped out during that 12 weeks. So we enrolled totally 23 patients, out of which 3 patients dropped out because they were one said they didn't feel like they could do it, and another two said that they 2 actually had other medical issues that came up that they couldn't spend time on the study anymore, so they left. So the rest 18 patients are on track to complete the study, showing that majority were able to do this. And then we looked at feasibility, meaning their adherence to plant foods. So before the study, patients were eating less eating about 20%. This is a median. So on average, patients were eating only 20% of their calories from unprocessed plant foods. So pretty much like a Western diet. On the intervention, it went up to 92%. And post-intervention, it still stayed high at 73%. And we also saw an increase in their fiber intake from 18 to 30. And then that's maybe slightly gone down, but still better than their baseline. We also looked at, what are the biomarkers or things that we know that are associated with progression. And we do know that, elevated BMI, insulin, IGF-1 have been shown to be associated with myeloma progression. And we were able to show that all of these actually kind of improved for the patients as a median change in 3 months. We also saw a decrease in inflammation. And with all of these changes, it meets its feasibility for weight loss because remember, these patients were eating to satiety. We did not calorie restrict anybody. They could eat as much as they wanted as long as they were just eating mainly plant foods and unprocessed plant foods. And you can see that there was also a change in their, this is a marker of insulin resistance. High means good and low is not good. And it actually improved. So there's less insulin resistance. Also, the microbiome changed where there's more butyrate producers and butyrate concentration. So now you might be asking me, what about the clinical side of it? Like, what about patients? Did anybody really benefit in terms of their M spike or myeloma changes? And I wanted to show you 2 cases. So this is one patient with MGUS who was diagnosed with MGUS in 2016, but had 2 other cancers prior. The M spike was 0.24. The patient had been on insulin for 30 years, so type 2 diabetic, and also had chronic kidney disease and a lot of other problems. In 2021, the patient started the study, so it's already been 18 months since they started the study or more, actually. And within a month of going on the study, the patient stopped insulin. The patient's 18 months out and has not taken insulin again. What the patient also we saw was that, this was their weight change before the intervention and this was on the intervention. But you can also see this is on the intervention that the patient lost weight but maintained the weight loss because it wasn't like they lost weight and gained it all back after we stopped. We also saw that the patient's, markers that we talked about improved, where their BMI improved, their A1C, stayed the same because they were well-controlled diabetic, but their insulin went down significantly, and so did their adiponectin-leptin ratio. The bone marrow plasma cells kind of stayed stable, maybe slight increase 18 months later, but what's more interesting is that this is the brown line before the intervention where their M spike was rising. On the intervention, you can see that it's stabilized. It looks like a short period because it's only this much, but it's actually 18 months of data, so it's quite a long time, and this was 5-6 years before that. What you can also see is their kidney function kind of plateaued as well. So this patient was heading towards dialysis with a creatinine that had been rising over time, and it seems to have at least delayed it or stabilized that as well. Another patient on the study who didn't have diabetes but had obesity and a lot of other medical issues started the study also 18 months ago. And what you can see is the patient had a reduction in their BMI, maintained that weight loss, so not gained it back. But you can see that their M spike again plateaued. And there were improvements even in their bone marrow plasma cells here by 50%. But again, I understand this is one case, and I understand that bone marrows can be patchy. So I'm not over-promising anything, but I'm just saying to you that this seems to have stabilized. What I'm also saying is, these are the 2 cases. So what you see in blue, this is time 0 when they started the study. What you see in blue is before the study, and then in red is on the study. And you can see the trajectory of the protein was rising, and then it's changed. So this is a little bit of like just looking at statistics, and it was statistically significant in terms of difference. So with that, we are doing now a much larger study, the Nutrivention 3 trial that's enrolling. This is 150 patients. So if anybody has MGUS or smoldering myeloma, any BMI can go on the study, but you would need to come 6 visits to MSK or to Emory spread over the course of 12 months. And you would get diet or supplements, which will be omega-3 and curcumin to understand the effects versus placebo. And everybody gets the diet eventually, and we're following them. So the study opened in December, and it's enrolling pretty quickly. We also Now in the next, so I talked about the prevention setting, and now I wanted to talk about the treatment setting. So can we use diet as a drug, meaning synergistically with therapies, to improve response rates like MRD negativity, overall survival, things like that? That is a little more challenging to study, but we have a study in acute lymphoblastic leukemia actually, where 40 patients were looked at and they were given a diet only for a month, but it was like a healthier diet where they were asked to follow eating certain foods, and it was 10% reduction in calorie intake. There was also some exercise component, and what you can see is that they had an improvement in insulin resistance, like the same marker I talked about, but they also had they looked at the MRD negativity rate, or the percentage of patients who had MRD compared to a historical control, meaning patients who were treated off the study in a similar fashion but didn't have this lifestyle intervention. And they saw a significant increase in the MRD negativity rate in the intervention compared to the historical control. Now, that's not the best kind of study because you really need patients to be in a randomized study and having this at the same time. So they are doing the next study like that currently, and we hopefully will have more data on that. Another place is like in melanoma. So this is skin cancer, not myeloma, but with checkpoint inhibitors, they looked at, they didn't intervene. They just asked patients to fill out surveys and tell them how much dietary fiber they're eating. And you can see that those who ate the highest dietary fiber intake had the longest survival compared to those who did not. And those who had enough fiber but also ate probiotics actually did similar to those who did not eat fiber. So it may be something to do with, when probiotics can reduce the diversity in the microbiome or change, because you're eating only a few strains of bacteria instead of when you eat the fiber, which allows multiple different strains to grow and have that diversity of the flora, like a forest with many different trees. And so in the last part would be, how do you use dietary interventions to improve survival, or how do you study that? And so what we're looking at is like, if you think about patients with no maintenance, could diet and lifestyle prolong the time to first relapse? With maintenance, could diet and lifestyle prolong the time to first relapse? And maybe a small number could be cured because they have, the immune system and other things are improved with lifestyle changes. So we did a study where this is again a non-interventional study, but we had a trial open where patients were on lenalidomide maintenance at MSK. And on that study, we asked patients to fill out diet resurveys, and we also collected stool samples. We looked at the diet, the microbiome, and outcomes in terms of sustained MRD negativity, which you heard a lot about. And sustained MRD negativity means MRD negative at 2 time points 1 year apart. What we did see is that patients who had more diversity in their microbiome, remember I talked about this, and had more butyrate producers and more butyrate concentration were more likely to be sustained MRD negative. We also looked at diet in correlation with this, and what you see is that patients that ate healthier proteins, mainly seafood, plant protein, but the effect is a lot through the plant-forward things because flavonoids are plant chemicals, and you can see that they were associated with the butyrate levels sustained MRD negativity too. The caveat to the study is it's a small study, it's not an interventional study, so I think we need more data to say very confidently that this can happen, but I think we're starting to see early signs of it. What you can see here is that this is the hypothesis, or what we think that is happening here, where diet's affecting the microbiome, and through these mechanisms may affect long-term control. We have this study enrolling at MSK currently looking at quality of life with lenalidomide or daratumumab. It's a randomized study. And a subset of these patients are going to get diet, so we can understand the effect of how diet interacts with immune therapies and how patients do on it. So, I think this is a very interesting statistic. So the fiber gap is something I don't know if you all have heard about, but 67% of people, and probably in this room as well, think that they're getting enough fiber. But when you actually go to calculate it, how many do you think actually get enough fiber? It's somewhere close. It's 5%. So very few people actually meet the fiber guidelines, and so the majority in reality are not getting enough fiber. And fiber is really important for the microbiome, the intestinal gut lining, and that's kind of what prevents or modulates the immune system and inflammation as one mechanism too. So I just wanted to give you an example because people always ask me this, and this is again a very arbitrary example, so you don't have to like follow it to the T or something, but it's just an example of like a diet that's probably more like a Western diet, and this would be a completely plant-based diet. And I'm just trying to show you so you get an understanding of where fiber comes from. Fiber comes only from plant-based foods, so if you eat something like broccoli, or you eat brown rice, you're more likely to get fiber. Even potatoes have fiber, but yogurt, meat, eggs are going to have no fiber. So this patient is getting enough fiber, more than enough fiber, but this patient is not even meeting the requirements for the fiber. Now you might say to me, and a lot of people say, what about protein? Like if you get enough fiber, you eat plant-based diet, you're not going to get enough protein. How do you get your protein? And so what I wanted to show you was that the recommended daily intake for protein is 0.8 to 1.2 grams per kilo. And if a person is 60 kilos, then they need up to like usually 48 grams. But if we say that somebody has cancer and they're on treatment or they're losing weight or they're older, then they need a little more protein. And in that situation, they need probably 72 grams on the higher side. You can see that with this diet, this person is adequately and maybe on the higher side meeting their protein requirement. And this animal-based diet is far exceeding the protein requirement. That very high protein diets are associated with worse metabolic health and also increased mortality and kidney disease as well. So I don't think more protein is always better. I think less protein may be a problem, but if you're getting adequate protein, I think you're going to be just fine. We don't see protein deficiency really in the United States, and very unusual. So in terms of nutrition changes, I've talked about a lot of things, but I think, you want to individualize it yourself. I am not here to overwhelm you or think that, you need to do everything overnight. But I think that if you're receptive to hearing about this or you feel like it will help you, it is a choice and you can decide what's right for you. I think it's also important to think about not just the cancer, but what are all the other metabolic issues that you might have going on? Is there elevated BMI, cardiovascular disease, diabetes, things that could definitely be impacted by diet? And then thinking about what kind of a person you are. Do you like making changes immediately and like overnight, or would you like to ease in with one change at a time, maybe adding a cup of beans a day or trying to meet the 30 grams of fiber a day and then seeing how you can do that and then move to the next thing as you achieve it? And so some practical dietary tips to consider is do not fear carbs, fear the refined carbs if you would fear carbs. And in that, eat enough whole grains, get your fiber, try to get the diversity of plant foods, eat more plant over animal sources of protein, and then think about eating more nuts, seeds, unsaturated fats, and getting your vitamin D as well. I think calorie counting and calorie restriction is not sustainable in terms of weight loss if that's something that you want to achieve, because it is focusing on what you can't do. It's focusing on not eating. But if you're trying to focus on the healthy foods and what you can eat and the abundance of that, I think it's much more sustainable as a lifestyle. And that is exactly why on our studies, patients are doing this even after the intervention for a long time after. Most of them, not everyone, but most are. And then the other thing is, if you have kidney disease and you're thinking about can diet affect it, I think this is a very good website to go to. This is the National Kidney Foundation's website, and they have a whole section on how plant-based diets are good for kidney health by affecting all of these things and progression, slowing the progression. So when I talk about plant-based diets, you might be saying like, oh God, I can't maybe be vegan or vegetarian or something like that, and it may be difficult for everyone, and I think everyone needs to decide what's right for them. But when I think about it, I think veganism comes a lot from thinking about global warming, thinking about the animal agriculture and things like that, but it may not always have to do with health. Some people may be doing it for health reasons, and I think that you can be very healthy being a vegan, but it depends on what your motivation is. In terms of vegetarian, I think that many people also you can eat junk food, eat fried foods, things like that, and could be vegetarian, but that doesn't mean it's always going to be healthy. And a lot of people do it more for religious or ethical reasons. But when I'm talking about it mainly from the health perspective, I think if you can get to 80 or 90% of your plate, this is the Canadian food plate, which is, I think, a very nice, unbiased food plate. But you can see that half the plate is fruits and vegetables, a quarter is whole grains, and a quarter is protein, but most of it is plant protein. So like only 12.5% of this plate may be meat, and the rest 87.5% is coming from plant sources of food. And so I say that if you wanting to do it for health reasons, whatever your motivation is, you pick the kind of diet you want, but make it be whole food, plant-based for the majority of your foods. And so with that, we have the Nutrivention 2 study that is going to open in a couple months through the HealthTree Foundation. And if any patient has smoldering myeloma, if you know of somebody who does, you can do the study from your home. It's a telehealth study, so we'd really encourage patients to participate. You would be just shipping us samples, and we'd be shipping you the food and supplements. So it's a short study, but we would really appreciate a participant, because I think this is one of the first that we're doing of this kind. But if we can, then we could do many more like this. And this is the survey we were talking about. If you could consider taking it, this is the QR code, where we're trying to understand, do dietary patterns differ between racial groups? And it takes about 30 minutes. You can save it and go back to it when you have time. And this is another survey we are doing on supplements that should open or maybe open already soon. And so if you're interested in participating in any of these clinical trials, you could scan the code and reach out to us, but many of them do require you to come to New York. But otherwise, we're happy to let you know when we have new trials. You can put your name in there. So just to conclude, these are some papers that we've written around how diet may affect cancer through different mechanisms. And so you can look at these papers in detail if you want. And I just want to conclude with this last thing, is that when you change your lifestyle to benefit your health, you're also benefiting the planet and global warming and climate change. And because one serving of beef is 1,200 grams per CO2 per serving, so that's the environmental impact, whereas one serving of beans is less than 1. So it's 1 to 1,200 in terms of the amount of environmental impact you have. And I think you would want to do that for, if that matters to you. So with that, I'd just like to conclude and thank, my team, my mentors, collaborators, and funding, without which it wouldn't be possible.